Okay, morning everyone. Thanks for joining us on this Monday morning. We've got the second webinar today from Sammy Stacknell, so in for a treat, a nice way to start the week. So over to you, Sammy. Thank you very much.
Thank you, Louise. Treat, yeah, we'll see about that. Thank you everyone though for joining in. I appreciate that it's sort of D-Day for dentistry in a couple of ways, because in theory we should all be back and drills at the ready, but yeah, if you're here with me, then things might not be quite the case. Well, otherwise I wouldn't be sat in my kitchen either. But no, thank you for coming along. And like Louis says, this is the second of my two oral surgery ones. And today I'm talking about Piezo surgery and oral surgery, and with a particular slant on implantology. Piezo surgery is one of those things that people have often heard about, but don't really know or understand. And so as part of sort of discussing techniques in general in implantology and oral surgery, I felt that this was actually quite a nice subject to cover. And I'm a KOL for Actian, so I get paid by Actian to sort of support their products and help them develop those things. That's my disclaimer out the way. But that said, I work with them because I like their products very much, and they give me free reign to sort of tell them what I think honestly and truthfully. So I wouldn't endorse them otherwise, but that's just, like I say, my sort of public disclaimer on the subject. So, right. So just very quickly, aims and objectives. Like I say, today I want to sort of explain why and where you might consider using Piezo surgery and where it's sort of benefit. But also I want to help cover some of the science behind it, because although there's the practical elements of using it, I think it's really important to understand why we use certain tools, because there's no point in any field, irrespective of what you do for your day-to-day, just picking things because a rep turns up and sells you a deal, or it sounds really good, or it looks nice on the floor of a trade show. It has to be practically applicable, and also we need to approach things with evidence-based. And there should be sound evidence to these things, and hopefully I can sort of demonstrate that today. And also just a small reminder around some of the healing pathways in hard and soft tissue, and where the clinical effects are felt most with Piezo. Very quickly, if you have questions and things, we'll do a Q&A at the end, so stick them into the Q&A stuff. Louise will deal with things as they crop up. If we don't cover all your questions, then by all means you can email in, you can get in touch, and I'll sort of try and answer them after the webinar as well. So just, like I say, put everything in the Q&A, and then we'll sort of work through them at the end. So just for those who weren't with me last week, this is what I do for a living, or that's at least what a lot of dentists think I do for a living, yanking teeth. Predominantly I do this for the NHS. This isn't a picture of me doing this for the NHS, but this I service an IMOS contract, so I take all the intermediate care referrals for Dorset pretty much. So it comes to around 200 plus referrals a week, which is a significant amount. So I spend a lot of time taking out teeth, so I get a great deal of experience doing it. But I also have a particular interest in implantology. So I was an ITI scholar last year. I spent a year abroad in Austria working with a team out there, learning more about implantology. And we use a great deal of Piezo out there, which was really fascinating, because I've come across it. I've obviously been using it for about 5-6 years. But it sort of has added to what I do. But as a dentist, as an oral surgeon, like I say, there are lots of things that we have to consider when we're treating our patients. And as an oral surgeon, it's not simply just taking teeth out. Like I say, we want to make sure that what we have has good evidence base to it, or as we explore the evidence base and help contribute to it as much as we can. And ultimately what we're doing is trying to improve outcomes for patients. And so when I take teeth out, whether it's NHS or otherwise, ultimately it's a patient attached to the end of that tooth. And in my last week's lecture, we talked about assessment, and it's about treating the person, not the tooth. And ultimately, as an oral surgeon, for me, it's really important to make sure that I still follow a restoratively driven process, especially when it comes to implantology. So I'm not just some tooth yanker. I'm not supplemental just to the process. I have to be part of that and integral to it. So when I take teeth out, I've got to ask the questions about what's happening later, what's coming further down the line. And part of that, especially if you're doing implantology, involves maintaining and preserving and utilizing tissues and working with biology, because ultimately that's one of the more important and complex aspects of what we do. Anyone can just about be a surgeon, but it's about understanding the craft that you've sort of got in front of you. So especially when it comes to adding new instruments into the mix. And ultimately, when we are practicing, we want harmonious, delicate, balanced outcomes, because we want to make sure that what we put in is going to last a reasonable amount of time and deal with the harsh environment that we put it in. Unfortunately, a lot of the time we see completely the opposite. And that's usually as an example of bad planning, bad execution. I'm going to hasten to add that this is not my work. These are the sorts of things that I get through as referral, where there hasn't been thought given to what else is going on. And you can just about imagine what the clinical picture was like when it was sort of uncovered. But for patients, oral surgery is very much like this. And that's the other part of what I want to talk about with Piezo surgery, is the patient experience. Because and I say to patients, I said this last week when I showed this picture as well, I'm not this agile. I don't climb the chair or mount the patient. So that's not how we do things. And we've moved on in lots of fields in dentistry. We've moved on in oral surgery too. But patients still feel like oral surgery is sort of a big bad wolf of sort of procedures, having teeth out, and it's about improving that experience. But why do we possibly portray that to our patients? Well, it's because what we're taught still looks like this. And although there's nothing wrong with learning the basics and the conventional aspects, you still need to have this as part of your base when you're sort of building your career as an oral surgeon or otherwise. But we need to understand, and I think it's something that we're remiss on in a lot of the undergraduate programs, and in some cases in particular, postgrad teaching in certain areas, where we still just teach the very basics and we sort of don't aspire to show people what else is out there. And I think there's a fine line, because we need to sort of both understand the traditional conventional wisdom so we can understand it and apply it to our patients, but also understand how we sort of improve and grow as clinicians and improve within our profession. So really that leads me on to talk about what is Piezo, because obviously you're here to hear about Piezo. And it was in thinking about what I used to do, knowing a bit about Piezo, that I got interested in it, because I felt that there could be a better way for me to apply what I did to patients, and there must be a nicer, better way to do it. So there's lots of different ways to sort of explain it and to look at it. But ultimately, the sort of diagram that I've got there up at the top looks at different ways in which ultrasound or ultrasonic waves are created. Now, the magnetorestrictive movements that you see there, that frequency where you've got a metal rod or stack of metal sheets. So sometimes if you take your scalar tips out, you'll see those metal sheets and the scalar tips. The way that the electric current is passed through those cause elliptical movements, which are sort of generated sort of pass through into the tip and generate that ultrasonic motion at the tip end, which along with the water causes the ability to remove things like calculus, hard deposits, because it acts at that frequency on hard deposits. Piezoelectric movement works in a slightly different way. It tends to operate at a slightly higher frequency in most instances, but it's a linear movement. So this was discovered in the late part of the 19th century, and it was understood that when you passed an electric current through usually certain crystal compounds, you had this linear movement on an almost microscopic level. And that could then be amplified, and those amplified movements could be passed through to the tip. First Piezo devices were then introduced in the early 2000s. So it was a while before we could really introduce them and start to apply them in medicine and dentistry. And in particular in medicine, it came a little bit earlier. It was used for hard tissue cutting. And this helps demonstrate this again a little bit more, just especially on the bottom, if you focus on the bottom picture about piezoelectric ceramics, because they are typically ceramics that form the basis of the piezo element on the inside of the machine. But the electric signal that is applied causes this linear movement that moves back and forth. That back and forth motion is very microscopic and requires amplification. And then if you can change what's at the tip when it is amplified, you can then change how that acts. So typically what we see clinically are micro movements on specifically designed cutting tips that look like that. And I think the picture in B always makes my eyes go fuzzy, but it's a great example of sort of how rapid this movement is in terms of ultrasonic vibrations. And it works in a horizontal fashion, usually back and forth, because of that linear motion that is caused in the ceramic. And that creates a very fine cutting motion when you apply the serrated edges like this to hard tissue. And I'll talk about hard and soft tissue in just a little bit, because a lot of people look at these things and wonder, are they going to do damage to other things? But we'll talk about that in just a second. The other thing that the piezoelectric motion does, the other thing that happens as a result of the frequency and the energy that's generated, something called cavitation. So cavitation is this process where a water molecule essentially inverts on itself and implodes because of the energy in its direct sphere. Sorry, in its direct that's in contact with the energy that is influencing itself on the water molecules. That implosion acts on the hard surface that you are cutting on, so in this case bone, and essentially the explosion at the surface acts to add to the cutting motion. So water, the irrigation, isn't simply adding coolant effect, which is needed. It also helps with the cutting effect. The other benefit to that is that it has a direct effect on hemostasis, which again has impact on clinical outcomes because it reduces things like bruising and post-operative discomfort because of swelling from bruising and bleeding. So there's benefits to how the machine works in itself and how the equipment works. And this is going to be universal to any piezo equipment that you see. This is how it behaves. Now, the important thing to start to consider at this stage, because the machine in itself is simple to understand. We sort of can apply the process of the physics of how it works, but it's what it does on the bone and in the body. And the diagram floating around here on the back of the screen is what you might remember from undergraduate days about, or even some postgraduate days, around the 3 different overlapping stages of wound healing. So from inflammatory to remodeling. And it's important in dentistry that we always keep a close eye on this. And the bits that I want to review now are going to be pertinent, say, when we take teeth out and when we consider implants. And one of the things that you may have forgotten is in any wound healing are the physiological markers that are a part of healing. So there's a whole list of them down there on the right-hand side of that image. And one of the key ones that we want to keep in mind there is BMP2. And you may have heard about it when it comes to bone grafting, and I'll touch again on that in just a second. But these markers are important because these are part of those 3 stages, and they're sort of color coded there to reflect those 3 different stages. And when it comes to taking teeth out, we know that taking a tooth out results in very predetermined, very predictable stages. So we know that when patients present at certain points with, for example, complication, it's because there's been a breach in one of those phases because something hasn't happened as expected. And you might be asking, why am I talking about biology and physiology? It's Monday morning, what on earth? But it's because this has direct relevance and impact on how we consider, like I say, the evidence base to why we'd want to use piezo. So why would we be using something if it's not going to be of direct benefit to any of this healing? So these videos are fantastic. Periospot, if you guys are bored, get on to Periospot. Dr. Barbosa is a phenomenal guy who does some brilliant stuff for implantology. And this is just to sort of refresh you about what happens along those different stages of tooth extraction and healing. And again, this is important from an implant point of view because it's had a massive influence on how we consider implant placement timing. And if you look at people like Danny Booz's group from Bern, they've really pushed forward on the early implant placement, so that 2 to 12-week period in which you place implants. And it's all based on these features here. So timing, which is a really important part. And that's all based on, oh, excuse me, that's all disappeared. My slides have gone. Yes, what happens in healing in the socket, healing of a canine, I can send those around to anyone, but you will have seen that it's basically the histological models of what I just showed there in that last video. But that same, you might ask, why is that important? Well, that same group, Danny Booz's group, was one of the first groups in 2013 to look with Vivian Chapuis, who's now head of that department in Bern, at what actually happens in real life, because it's all well and good having physiological models or cartoons of what happens in beagle dogs, but what happens in the real world, and is it different for different people? Well, they were one of the first groups to get cone beams done at the time of extraction, and then subsequently at about 8 weeks to look at what was happening in that early physiological remodeling of buccal plate, especially in anterior sites, so in the aesthetic zone, because this is obviously where we care an awful lot about what the outcomes are going to be. And they could generate these heat maps like you see on the right hand side to show volume loss. And they came to the conclusion that there are essentially two types of buccal bone plate. So there is basically thin biotype bone. We talk about biotype when we can't talk about soft tissue often, but we can apply it to bone, and that is less than 1 millimeter thick, and thick biotype, so that of 1 millimeter or more. Now, though you can see the thin on the left and the thick on the right there, and essentially what they concluded was that thin biotype would recede anywhere up to 7 millimeters in terms of bone loss, whereas thick might only recede up to 1 millimeter. So that has direct influence on how we're going to manage that later when we come to graft and manage these cases. But with regards to immediate healing and immediate management, if you're removing teeth in thin biotypes, you all of a sudden need to start reconsidering how you're taking that out. Now, bundle bone, that thin buccal plate, that's essentially an inherent part of the periodontal process of anterior teeth in that aesthetic zone, that is going to disappear. The remodeling in all of these cases is going to happen irrespective of what tooth or what patient you have. That's something we can't escape. We cannot change biology. If you fight it, you'll lose, because biology has been doing this an awful lot longer than we have. So we have to work with biology, and we have to think about how do we minimize risk to change. And that's important, because if we are, like I say, putting implants in, if we can reduce the amount of bone reduction that's going to be inherent, so that's timing of implants, and this is beyond the scope of what we're going to talk about today, because it's entire lectures in its own right. If we can reduce the amount of bone that's lost, then we reduce the amount of bone defect, and we can reduce or maintain the amount of bone that's needed to be replaced for patients later. And it's not just anterior sites, it's posterior sites as well. So this is a case that got sent to me where an extraction went really, really badly. The buccal plate came out, OACs created. And this is the sort of site that's now going to need significant regenerative intervention to get it back to a place where a, say, fixed prosthesis might be used without massive soft tissue deficiency on top of that, unless the patient wanted to go down the route of removable, which they didn't. So it's not just anterior teeth where we have to really care about how the tooth is coming out. It's all teeth, because it can go wrong really badly. And I'm not saying that any one particular person is worse than another, but without the right equipment, without the right training, without the right consideration for what you've got in front of you, this can happen. It has happened to me before. It will happen to absolutely everyone, where extractions don't go as well as planned. So if you can introduce techniques and ways to try and minimize the detrimental effect on the extraction site, all the better, because it's going to help preserve whatever tissue you have left there. So moving on, thinking a bit more again about factors that affect things like healing and implantology, because ultimately that's where a lot of people are being driven in their decision making around how they're managing their extractions. I treat every extraction as though it was a potential implant site, and I think that's a generally good attitude to have, because we should give everyone those options, and everyone should be able to take those options on if they so choose. But we need to consider, like I say, the particular elements of healing and the healing elements that we can control. And that's something that, like I say, we need to keep going back to. Biology will do what biology does best, and we can only control certain things. And there are lots of papers out there which have discussed different factors. Now, some we can control, some we can't. So again, some of it's patient selection. So you can choose your patients. You know which ones will heal, which ones are going to get dry socket. You know which ones are going to be more complex. You know which ones you will or won't treat, which ones are going to be suitable for implants. But there are some things that we can manage. And when it comes to local factors, that's probably the more influential area that you might have. So if we can reduce a degree of infection risk, if we can reduce foreign bodies in the area, if we can make sure that the tissues are healthy, oxygenated, and that there's good blood flow and blood supply to the area, so that harm is less likely to happen in terms of healing harm, then that's exactly what we want to control. Like I say, some of the systemic ones we can't control. We can't stop our patients being diabetic or take them off their steroids necessarily, but we can influence what we do in that local site. So taking care with what we do. And again, when we manage bony defects, when we consider the size of bony defect, if we can reduce the size of the bony defect, there's the potential that we might be able to influence the outcome of what you're then going to graft or place an implant into. Now, although single wall defects might not discriminate, like this paper showed, one of the risks with creating single wall defects or intra-bony defects is that the larger they are, if you end up with a one wall defect, you've got less blood supply for bony infill later, because ultimately you need good blood supply for bone to happen. So this is now thinking past the point of having taken the tooth out. It's what are you leaving there, so that when you come to place an implant and graft, are you going to have enough blood supply to generate new bone when you inherently need to fill that up with a particular matter of whatever type you choose. And the bigger that jumping gap, the harder it's going to be. The more walls there are around it, the more likely you are to have good blood supply, because there's a greater surface area. And that's one of the crucial things that we need to consider whenever we're taking and planning implants. And again, that's prudent when you come to things like molar sites. And again, molar extractions and molar implant placement is different, but the more you can reduce that jumping gap, and we know that that jump gap is maximum 2 millimeters around the implant, the better the bony infill is going to be. So again, reducing damage to the bone walls, because if you're taking a rotary instrument to these things, you're going to be doing more damage. You're going to be increasing the width of the defect, the size of the defect, and doing damage to the bone at the site there. So where do we start to consider using Piezo? Well, Piezo, like I said, was first introduced in medicine in the sort of 60s, 70s in sort of other hard tissue surgery, but it wasn't until the 90s that the Italians actually started using this. And predominantly it was for sinus surgery because of the way that it cuts and the way that it manages hard tissue. And it helped exert a degree of control that hadn't really been seen in oral surgery before. So these are the sort of things here on this list that Piezo started to find some relevance for. But ultimately, the reason we want to use Piezo is going to be because we want to control the trauma. So, you know, thinking back a couple of slides now, what I've said about healing factors, we want to minimize the damage that we're doing to an area and maximize our control, because again, it's about improving predictability. So knowing what are we going to be able to do to net the best result later down the end. And if there are things that can improve outcomes, so bone growth, then even better. So that picture that I showed earlier about with healing factors in there, well, it's well known now in the evidence base that Piezo surgery increases the production or the presence of certain healing factors. So BMP2, bone morphogenic protein, is an integral part to bone healing. And we've seen in the US, lots of institutes have been developing injectable BMPs as part of bone growth to try and help stabilize and improve graft outcomes. Well, using Piezo surgery, we know that there is going to be increased osteocytic activity, generally, osteoclastic activity initially, and ultimately better expression of some of these proteins. So we know we're going to preserve and save some of these bony cells. Now, this is from another paper. I can get you the references if people are really that interested. I can find the references and send them on, so just let us know. But this was a study that looked at the histological outcomes of the differences between carbide burr, rotary disc, and then Piezo cuts through, I think it was rat fibula. Now, you can see the differences without me even explaining what the differences probably are. And the scorch marks that are essentially there in the cuts are an example of the damage that rotary instruments will do because of the friction that they exert compared to those ultrasonic vibrations that you generate with the piezo tip. So the piezo tip is able to cut much more cleanly in that far right of the three pictures. And that is inherently useful because when you reduce the amount of damage that you do, you're going to improve the outcomes. I think that's almost a dead set. That sort of almost goes without saying. But these papers have started to show that the reduction of necrotic bone has a direct influence on the bone cell viability afterwards, because there's more of them alive. There's more of them there to do the job that they need to do. And when we start to compare piezo to rotary, more and more papers have started to show that heating the bone, which is something that happens with rotary, we end up with cellular damage. So these osteocytes are damaged as a result of friction from the bone. Now, Erickson et al. Showed that 47 degrees for over a minute was enough to kill pretty much most viable bone cells. Now, collectively, if you are sat there hacking away around teeth because you've got roots stuck or whatever, and the irrigation's not getting into that cutting site, you will be doing more than a minute's worth of damage to bone. And that's why sometimes there are suggestions that that's why people will come back with dry sockets. That's why people will come back with postoperative infections, because the bone cells are just not there. They're just not active. And physiological stress, so on an even more biological basic level, heat shock protein 70 is a marker for stress. So it's a physiological marker for postoperative stress, something that you can measure almost directly as a result of something like oral surgery. And there was, in some studies, up to twice as much heat shock protein expressed with rotary instruments compared to with piezo. So the evidence and the science starts to show us that we've got better viability of bone cells, better expression of useful physiological markers, so bone morphogenic protein, and the stress markers, so the things that are going to be showing detriment to the body or the healing sites, so heat shock protein 70. All of these things start to add up in favor of piezo. So these things start to show, these examples start to show that there is benefit to using alternatives to what we normally do. And when you're considering things like immediate implant placement, a lot of people just wonder whether, what are the uses of these instruments? Well, you're obviously considering several elements when you're considering things like implant success, and immediate implant success in particular. And this quote is from a paper. Again, I can get it for you. It's one that I've used throughout this presentation. But piezo surgery, again, in the evidence base, starts to show that there are lots of similarities between preparation for implant sites with piezo as with rotary instruments. But the benefit is that even, for example, if you're collecting bone particles to supplement the area with another tip, these are optimal sizes, the low heat generation improves outcomes, and there's better survivability of osteoblasts, osteocytes in things like bone blocks. So all of these elements add up and are going to be synergistic in their effects and then their outcomes later down the line. So when we start to consider soft tissue, and I'll only touch on this briefly because there's not really much to say about soft tissue other than the fact that the effects of piezo are virtually nil on soft tissue, which is what makes it so brilliant. And it's one of the reasons we started seeing its use in things like sinus lifts, because we saw a much gentler approach to the Schneiderian membrane, and also in things like nerve lateralization, because you're going to be able to make cuts more safely without putting soft tissue at risk. And one of my favorite papers is this one where they tried to do damage to rat brains, and I don't believe they were living rats, but they basically put piezo to make calvarial cuts, and looked at the impact on the neural tissue afterwards histologically, and that tissue was sound. And that's then again amplified here on the right with these histological slides looking at the differences between carbide fish and round burrs cutting into. So they were used consistent levels of pressure to place the burrs on soft tissues on a region of, I think it was rat tongue as well, and looking at how much depth of damage would be caused. Now, image D is that from piezo surgery. That dent in that paper it needed 50 times the amount of pressure compared to the other slides to create the dent. So that is a significant amount more damage. Now, the thing to note as well that this paper highlighted was that the dent didn't actually result in a breach of the epithelium. So although it physically dented it, it didn't actually do damage, which again is really significant. So that's more pressure damage, the fact that you're leaning heavily against something that's doing the damage rather than the cutting tip. Now, don't take that as though it's completely safe. Yes, anyone putting excessive force on anything can do damage. So if you're leaning heavily around nerves, you're going to do damage. No instrument is 100% safe, but the vibrations that the piezo acts on at about 50 kilohertz the 50 kilohertz is the minimum limit for when you will see soft tissue damage. Whereas, as from the earlier slides, piezo operates at a much lower frequency, so it's safe from the vibrations point of view. And the benefit to maintaining some of the bone and the soft tissue here is that the more you can reduce relieving flaps, the better, because if we can reduce tissue alterations, so you may have heard the phrase where the bone sets the tone, but the tissue is the issue. That tissue is the issue because typically it's been a flap that's reflected and that's been removed and remodeled, and you get flap shrinkage. And what patients are going to see and complain about is the fact that there are soft tissue shadows, that there is darkness around, say, teeth or where teeth have been removed. And if you can reduce the amount of damage you're doing to soft tissue, better for patient outcomes later on down the line. So now we've talked about histology and the sort of biology behind it. Obviously, there's the real world implications. So why should we bother using this for our patients? What are the patients going to see, and what is it that we'll see and notice? Well, first things first is that it's safe. And I think I sort of touched on that talking about the soft tissue elements here. In orthognathic surgery, so that is essentially breaking jaws and moving them around to compensate for occlusal discrepancies, there was impact on blood loss and nerve and vessel integrity. And we know that using piezo will preserve and spare nerve tissue. So there was reduced things like numbness afterwards. There was reduced blood loss. I mean, largely that being said, orthognathic surgery these days, with the techniques that people use and the skill of surgeons, blood loss is relatively minimal. We don't tend to see it very much, but again, the precision of these cuts is better. And again, for nerve transplantation, nerve movement, in some of these more advanced cases, patients are reporting less numbness. There's less risk, less damage to soft tissues as a result. And again, when we take it back to even simple and simpler dentistry, comparing piezo versus rotary, patients, although they might have been in the chair slightly longer, and I'll touch on that shortly, they have reported less postoperative swelling, better outcomes afterwards, better quality of life. So again, it's about patient experience, because the patient doesn't necessarily know what technique you are or aren't using to take teeth out, but they know what it's like when they go home. They know how many painkillers they take. They know how many days of downtime they have. So their experience, their quality of life measures are a really good indicator of how good something is working or isn't. And rotary is less predictable to a degree. Now, I haven't thrown my drills away. You know, my drills are still sort of center stage, but they will do damage, and you have to operate them carefully. And if you don't have the right or appropriate training, a drill will do damage, and that's the same in anyone's hands. But there are risks to things like soft tissues. There are more postoperative complications potentially. And sometimes in tight confines, it's harder to operate. It's harder to get irrigation. It's harder to manage rotary instruments. So piezo has the benefit of being faster. The rotary instruments have the benefit of being faster, but they are more traumatic. And when we look at some of the studies that compare the timing in terms of time in chair when it came to looking at routine methods with wisdom teeth. Now, I don't know who was taking 72 minutes to take out wisdom teeth with piezo, but because they certainly don't when I sort of do them, and the same for rotary, those are long treatment times. I have a sneaking suspicion that these looked in a dental school because the times are quite slow. But still, when we look at other surgeries as well, when you're comparing piezo to manual, there is an increase in the amount of time that it takes to do things. And But that is then, if you think about the relationship to things like postoperative pain, Piezo shows less postoperative pain. Piezo shows improved outcomes and less complications. So the time that you're probably losing in terms of surgery time versus probably the amount of time that you spend getting patients back in and managing them later or talking to them on the phone because of postoperative complications, I think that offsets it. And I think if the patient experience is better, that does wonders for you as well, because they're going to go and tell people about the brilliant piece of kit that you've used and that how their extraction didn't hurt. So if we look at Piezo extractions versus rotary, we know, oh, sorry, that slide is overlapped there. There are papers out there exploring the idea of flapless removal of teeth. And the idea is that when you use conventional instruments, conventional forceps, you apply much more leveraging forces around teeth, and the risk of fracturing things like buccal plates and the alveolar process is much higher. Whereas some of these, this technique called flapless boning, which is basically using the Piezo instruments, so the specifically designed tips like luxator tips to help separate the periodontal ligament and create space down between the alveolar process and the tooth, that reduces the need to raise flaps. It reduces the trauma of the procedure itself. And that is significant benefit. Also, when it comes to things like implant preparation, if you are removing a tooth, obviously an implant's not going to maintain the buccal bone, but you want to reduce, like I said earlier, the amount of buccal bone that's damaged. So you're reducing the gap to jump, you're reducing the amount of bone that might resorb, you're removing the tooth more atraumatically, and you're maintaining the bone, which in this case is going to be the supply for the blood supply. Sorry, that is going to be there for particulate matter that you pack in around it. So taking these teeth out atraumatically, maintaining flaps and not having to raise flaps, this is all these are all benefits here to using Piezo when we're taking them out. And again, like I say, it supports revascularization because that boning process isn't damaged. So very simple video to show the sort of differences between sort of rotary and excuse the great music here. So to show, I'll just speed it up for you guys a little bit, but just so you guys get an idea of the differences. So the fact that we can use this incisionless, and I'll show you a video now with a live case just after this, but the idea is that we use this almost like a luxator. So we can do this without necessarily having to raise flaps because it's not doing damage to the soft tissue. When you're using, obviously you wouldn't be using a fast handpiece like they're doing there, but with a fast handpiece, to try and gain application points, you're essentially removing bone. So you're creating bleeding, you're creating damage to the area, and you're more likely to still break the tooth, because what's happening on the left there, once you've created that Piezo incision, is you've created a space around the tooth. You don't necessarily directly cut it, but you remove the periodontal ligament and you separate that, and it makes it much easier to remove. With conventional instruments, you are still leveraging on the tooth in the conventional ways. So it's still acting in a very heavy-handed manner and can do damage and can remove bone with it. So in some cases, ankylotic teeth, that will come out. So the significance and the difference, we know that that exists. So excuse me, I'm going to move on. So here is that exact same thing, but in the real world, on a patient that I had with a wisdom tooth. And this is all real time. So the only thing that I've removed essentially is numbing the patient up and getting them to that point. So essentially what I'm doing is working around the tooth with that finely designed tip that you sort of saw in the cartoon earlier. And the idea is that I'm finding a point that the tip will disappear down that periodontal ligament space. And then I just essentially work around the periodontal ligament space however I can. So it's like using a luxator or a piezotome, but this is amplified. This has the power to do a little bit more. Excuse me. So that is literally it. And you can now just about see the amount of force that I need to sort of remove that tooth. Okay. It's done incredibly quickly. That is a 5-minute procedure. Okay. They're not all 5 minutes, but they are significantly quicker. And a couple of other, hang on, if computer wants to behave. These are the types of cases that I get in as an oral surgeon. Stuff that a lot of people don't want to do. And conventionally, cases like this are cases where I'd think, okay, actually, this is something that will need a flap. This is something that might need buccal bone removal. This is something where 2 roots will need to be delivered. And these are NHS cases. These aren't private cases that sort of get special treatment because they're private. I will use my Piezo on every case where I think it's necessary. And I think if it's going to be of benefit to that patient. But if I can move away from having to raise large flaps and actually speed up my turnover time, that's only going to be of benefit to me, but it's of benefit to the patient as well, because the patient now doesn't have sutures. They even got to keep their little soft tissue flap there that they had around the tooth. There is going to be a general improvement. But again, for implant patients, large first molar here that's heavily restored, that isn't going to be savable. The 7 behind it was crowned. I did an implant on the contralateral side for this guy, and taking the tooth out was an absolute misery for me, and that was with conventional rotary. And I thought, oh, this time around I'm going to give it a go with Piezo, see if that changes things. And yes, it certainly did. That tooth came out, no flap, absolute clean, no issues. And then I was able to ridge preserve the area afterwards, and we went on to put an implant in there, and that's been fantastic. And that was a completely different experience for the patient. And he noted how different it was from one side to the other. Just anecdotally, the report is there from the patient, how much they sort of see the difference and feel the difference as well. So obviously I've talked about taking teeth out, and you can manage teeth very well, but management of the sinus is one of the traditional things that we used to do use Piezo for. And these two I will sort of just play in the background whilst I sort of talk over them. But what's interesting is, like I say, traditionally we used to use Piezo for the sort of window creation. That was where it came from. That was what the Italians did. So where you've had teeth loss, pneumatization of the sinus, reduction of the alveolar process, in both cases, that's going to be exactly the same. If you can do an implant placement at the time, we're talking at least 4 millimeters, 3-4 millimeters of residual alveolar crest there to create implant stability. You can do it transcrestally. Now, that bottom right video is talking about it transcrestally, and essentially what you're doing is creating the osteotomy site using the Piezo tips. That's not necessarily my preferred method of doing it. I don't necessarily enjoy that technique. In my hands, it doesn't work as well. I use things like the VersaBurs as well. However, I may use the Piezo supplementary to this. And the interesting thing is that if you look at some of the godfathers, the Italian guys who are sort of the real big names in sinus surgery, a lot of them have moved towards using, they still use Piezo as part of this, but for example, they will do their transcrestal approaches using things like the VersaBurs, which I'll sort of talk about briefly in just a minute. But if those fail, then they will use things like their Piezo to back up, to raise a bony window like you see up there on the top left, to do a more traditional and conventional sinus lift approach, because they want to reduce the amount of damage that they've already done, because they may have torn the window and they may have done damage to the sinus membrane. So the last thing you want to do is more damage. And again, the fact that you can maintain smaller bony windows and more control is better. And sometimes, depending on thickness of the bone, that sort of thing, you may find that this Piezo is a better way to do it than conventional rotary. It takes more time, granted. It is going to be a longer process with Piezo. And I know that firsthand, it usually takes me longer. However, for example, where you've got blood vessels that are sort of in the middle of the bone, or that are visible, and you think you might do damage to the Schneiderian membrane, or to cause a bleed or a rupture, well, then that is where Piezo is going to win every time, because again, Piezo is going to stop you from doing damage inadvertently to what you've got there. So I think hands down for Piezo, Piezo is always out whenever I'm doing any sinus surgery, because I know it's going to be a safe and predictable way to manage it. So, excuse me, that's the next one. So, ridge widening. Ridge widening is another procedure that we've sort of seen come to the forte, and it's been going on for years, but we've seen it again. There's some great courses out there at the moment on ridge splitting and ridge widening. And whilst this is playing in the background, like I say, you would have seen there in the cartoon, the specific tip kits. So all these tips will be designed particularly with the process in mind. Now, I don't necessarily just use the ridge widening kit and do the splits as they would do necessarily here in the cartoon. I use some of the Versa protocols. The Versa burrs are essentially osteodensifying burrs. They're burrs that are designed to be run essentially in reverse torque, and they cause a spreading and a widening of the ridge. Now, I think they work fantastic in the regular protocols that they do, but when you've got wider bone ridges, in order to compensate for the amount of bone deficiency that you're going to get buccally, because typically you don't just have small ridge. If you've got a small ridge, you can block graft it, or you can sort of expand or graft around the implant where you've got the placement. But if you're doing multiple units, from an aesthetic point of view, you want the soft tissue contours as well to match what you're doing around your tooth. So it makes sense to expand the bone in its entirety and improve the ridge width and improve that stability around there. And I think it makes for a better prosthetic management of the patient ultimately. So what we essentially do is create the osteotomy sites, but through the alveolar ridge split. So the difference between what the cartoon is showing is that in the cartoon, they'll be making some more vertical splits up the sides to try and help, which is what they're doing there right now. And yes, you can expand out the ridge that way, but to me, that's riskier because you stand a greater chance of creating a buccal bone fracture. You can out fracture that, so you need to have your screw kit around to stabilize that in case that goes that way. Whereas with the Versa kit, once you've done the alveolar process cut, you can expand that entire ridge outwards, and due to the elastic nature of the bone, that will respond quite favorably, and then you can pack down graft material in between. So essentially, you've kept your two cortical plates. This is obviously technique sensitive, and I do suggest you go on some bone grafting courses if this is the sort of stuff you want to do, because it's good to get the hands-on practice and also to get the mentoring to get good at these sorts of things. But these are the sorts of things that you're able to do in terms of maintaining the bone and splitting it quite atraumatically and reducing the need for bone grafts. But again, this is case specific, and you've got to pick your cases carefully to make sure you've got the sort of right patients to do it. Piezo-assisted orthodontics, so something that you guys may not have heard of. Some of you will, some of you won't, but what everyone is into with aligner therapy and quick orthodontics, there is a way to improve the speed of orthodontics without necessarily the overly quick orthodontics, which can do damage in itself. And that is piezo-scission. And piezo-scission is this concept that, again, has been around for a few years, but it came as a result, and it's been around for decades, but under other names. Essentially, this idea where you create bony cuts and this damage to the bone ultimately creates an increase of the videos frozen there, an increase in bone activity, again, osteoclastic activity, which enhances the rate at which teeth will move through the bone. And the systematic reviews and the meta-analysis around this, although there's some debate around the efficacy of this, it's been decided that this is a safe way to do it, and it can improve the speed. Again, obviously, there are going to be risks for complications such as damage to teeth if you're not careful. It needs to be careful planning around these sorts of things. But by creating these buccal bone cuts, because there's very limited incision, there's very limited cutting, the piezo is very gentle, you tend to have very good post-operative outcomes, and you tend to have reduced overall treatment times for orthodontics, and especially in very complex movements where you might have difficulty moving things and you want to accelerate, say, impacted canines or very teeth that are in incredibly ectopic positions. This will help, and this is a very useful way to consider it. Again, there's some great courses that are being run around piezo-scission to try and help facilitate these sorts of things. And again, outside of the scope of this lecture to sort of talk about it, it's an entire day in itself almost. But something that I wanted to share with you guys as a potential way to use piezo, because ultimately there isn't just one thing that these instruments are good for. There's lots. So that's hopefully covered a lot of things today. It's always difficult in an hour to sort of cover everything, but I hope you've seen the benefits to why I think piezo is great. I think there's lots of science to back up why it's of benefit. I think there's lots of reasons to show the improvements that it has for both clinician and for the patient. And also, like I say, you don't just introduce new instruments for the sake of introducing new instruments. It's all about making sure you've got good sound reason to do so. And if you can improve what biology is doing and assist it in some ways, then I think all the better. Technology has come on an awful long way, and these kits aren't necessarily cheap, but I think they've made a massive difference to how I practice, and they're a great safety net. I find myself reaching to them for more and more cases. And like I say, these days, the Piezo gets set up with the rest of the surgical equipment. It's definitely part of what I do day to day now. But it's one instrument with multiple approaches. So it's got lots of additional facets that it can be used for. So for me, it's a no-brainer. But I hope that this has, like I say, helped cover some of the basics of Piezo, helped you understand a little bit more. But thank you so much for listening. I really appreciate it. And I think now we can take some questions. So thank you very much, guys. I'm going to just get to the Q&A, and I think Louise is going to give me a hand here.
Yeah, you've got, I think, 5 questions at the bottom.
Right. Just trying to see if it's coming up.
If you click back on Zoom.
Yeah.
Let's do this for you.
Okay, it doesn't seem to want to come up. Oh, hang on. Okay, here we go. Right. Sorry, there we go. So how about, first one from Nadia, how about ankylosed teeth? So ankylosed teeth, so is it easy to use? Yeah, it can be, absolutely. It will help with the cutting mechanism. So, I mean, again, when they're ankylosed teeth, the level of bone removal that you can actually create is going to be variable because it's not always predictable. However, because the cuts are finer, you can control those cuts a little bit more. So I find that with rotary, you've got almost double, if not 3 times the size of the cut. So you can preserve a lot more bone with ankylosed teeth. So definitely makes a lot of difference. Dr. Sachdev, what material did I use for ridge preservation? In that one, that was an alloplast. I went through a phase where I was using alloplastic material. I have moved more back to some things like the Geistlake biocollagen, BIOS collagen, just because of the stability, the evidence around it, and some of the clinical outcomes that I've been getting. I think they're more predictable. There is on the Geistlake Facebook, the clinician's Facebook site, I did a whole talk on Piezo and ridge preservation. So it's sort of a combination of this one and some bits on Piezo. So by all means, go and have a look at that because that'll sort of explain it probably a little bit more. And you also ask about ridge splitting. What's the minimum ridge width? So normally you want about, I think, 4 millimeters. And you need to, more crucially on the cone beam, see a differentiation between the cortical plates. If there's a fusion of the cortical plates even at the top, it's going to be very difficult to get down there to create the split. So if there's fusion, block graft, that's what you're going to sort of be stuck with. But as long as you can see the 2 different plates and you've got at least 4 millimeters, you should have enough to sort of get in there to split, to even put sort of a 3-4 millimeter fixture in there as well. But don't think that just the ridge split is going to be enough. You will need supplementary grafting to help it. Courses for this, courses for Piezo. Well, Bard is going to be hosting some more teaching. At the moment, hands-on courses are a little bit tricky just because of obviously everything with pandemic. If you stay in touch, if you follow us on social media with Bard on the Facebook group, if you follow me on Insta, I'm just Mr._Stagnall, or Twitter at Sammy Sagnall, get in touch by all means, and sort of I can keep you posted on when stuff is coming up. A Piezo, it varies again in terms, sorry, I'm going to go to the next one. Uses of Piezo. How much does it cost? Trying to remember this. It varies, but Actian have done a lot of good deals. I mean, the Mectron units are very good. NSK are decent units as well. It varies from different company to different company. The Actian ones are very competitively priced. They're the ones that I use, and they were giving some free tip kits away with those as well. And I know Dental Directory was working with, and so was Optinent, I think, was working with Actian to get good prices on those. And I think they were, don't tell me off too much if I'm wrong, I think they were about £3,500 British pounds. Plus VAT, and that was a little while ago. Again, it's worth getting in touch with your distributor just to find out. Piezo surgery and current clinical situation with AGP. Well, to be honest with you, I am not using it yet because I haven't gone back. So I don't know what I will or won't be using, but it's a very valid question. I think, yeah, piezo like ultrasonics is going to be very much an AGP because of the sort of the mist that it creates with the irrigation. I think that whilst I'm getting started and finding my feet like everyone else, I'm not rushing into just using it. I think, I may well rely on more traditional techniques, but also we're going to be selecting and managing our patients very differently to what we were sort of originally. But again, anything that I do, which is going to be an AGP, I will only be doing if I have the right set up PPE and the correct equipment, and the patients are informed properly and the team's ready for it. So yeah, I think maybe not just yet, but we'll definitely get there. So cool. I think that's all for questions. I can't see any more.
No, I think it's just one. Someone's put one in the chat, Sammy.
Oh, right. Someone's put some. What's the best way to get into the oral surgery training and pathway? Aha. Oh, wow. Loaded question. How much time do you have? I'm going to assume that this is in the UK. So UK oral surgery now is, as a specialist, to do specialty training. So to become a registrar in oral surgery, you go and do national selection. So it used to be different deaneries, different areas that were broken up, but now we have national central applications, so similar to how we do dental foundation training, dental core training, and people just apply to a central list. You don't know where you might get ranked or placed, and then you go from there. And then essentially oral surgery is about 3 years full-time training, 4 years if you're academic. So the ACF posts, which are sort of co-funded by the National Institute for Health Research, you will go through all the competencies and get to oral surgery training that way. But the other routes of sort of non-specialist training, but sort of application by equivalence, that's up for a lot of debate, and there are portfolio entries, and you would still need to potentially sit specialty exams, which you can sit if you've done things like an Implantology or a master's sort of at this on the side. Much trickier, much less predictable. So yeah, we need more oral surgeons, definitely. I think in the UK, there's been a bigger push towards tier 2 oral surgeons, so accredited professionals. So if oral surgery is your thing and you enjoy it and you've done extra education, you built a portfolio, built a logbook, do some part-time work in hospital, a lot more of the IMOS work, so intermediate oral surgery, is being done. And it's sort of that dentist with special interest realm, which I think is growing and is definitely a great way to sort of be part of the specialty. You don't necessarily need to be a specialist because, but it is, like I say, quite competitive to get into oral surgery. But yeah, by all means, get in touch if I can help. More than happy to. And someone's just added another question. Did I say that Piezo would inhibit osteoclastic? No, Piezo will improve osteoclastic activity and osteoblastic activity. So it preserves osteocytes. So I'm sorry if I confused anyone there. It's rotary that tends to do damage to the osteoclastic activity, usually because of necrosis of cells because of tissue changes due to temperature. Cool. I think that's everything. Thank you very much for your time, everyone. There are some more great talks from Bod over the coming weeks. Paul and the entire team at Tipton Training have done an immense job pulling together everyone in the way that they have, and I'm really grateful to have been part of this. So thank you, Louise, Paul, and everyone for helping me be joining on this. I hope this was useful for everyone from an oral surgery point of view. Any more questions, anything else, by all means, email Louise and the team at Tipton. And I think that's it from me.